Assalamu alaikum. This is Dr. Mariam Al-Abdallah, a professor in orthodontics at the University of Jordan and the senior orthodontic consultant at the Jordan University Hospital. Our talk today is going to be about orthodontic tooth movement. We have two references, Chapter 8 from Contemporary Orthodontics 6th edition by Prophet, and Chapter 5 from Handbook of Orthodontics by Coburn and DBA 2nd edition. Now, as you can see, this is the one from Prophet, and these are the outlines. This lecture is going to cover the first two parts of these outlines. Okay, this will include periodontal and bone response to normal function, and periodontal ligament and bone response to sustained orthodontic force. Okay, these are a few questions to get you started. How can the mechanical stimulus that is applied to the tooth be translated into cellular changes and then end up remodeling the periodontal ligaments and alveolar bone and then end up causing tooth movement? How can cells tell the difference between the pressure and tension areas and respond differently? Physiologic and orthodontic tooth movement. What is the difference? Short duration and long duration forces that is applied to the tooth. How is the reaction different? Light forces and heavy forces, sustained forces in specific. How can this be different in terms of reaction? So these are really nice questions to start off with, and we will be answering this in this lecture. Now, each tooth is attached to and is separated from the adjacent alveolar bone by a heavy collagenous supporting structure, which is the periodontal ligament. Okay, so we will talk a little bit about this space that is separating the tooth from the bone. Okay, and it's around 0.5 millimeter width all around the root area. This space is filled with extracellular matrix, which is collagenous fiber bundles, mainly type 1 collagen fiber, ground substance like proteoglycans, glycoproteins, oxytocin fibers, large number of growth factors. And then we have cellular elements and vascular and neural elements and tissue fluids. Now, this space, this periodontal ligament space, plays a very important role in the normal function and in making orthodontic tooth movement possible. These ligaments that are occupying the periodontal ligament space, they run parallel from the alveolar bone to the cementum, but they are not parallel to the horizon. Okay, they run at an angle. They are parallel to each other, but they run at an angle, which is attached further apically on the tooth than on the alveolar bone. And this is very important in order to resist the displacement of the tooth during normal function. When we say normal function, that means, for example, chewing, okay? So occlusal forces, when they are applied to the tooth, these fibers and the angle that they are attached from the bone to the roots, this angle will actually prevent and resist displacement of the tooth further apically. Now, we said that there are cells within the periodontal ligament space. These cells involve the undifferentiated mesenchymal cells and then cells that are responsible to remodel the collagen fibers, and that's the fibroblasts that produce a new collagenous matrix material, and the fibroclasts that destroy previously produced collagen. And then we have cells that are responsible for bone remodeling. That includes osteoblast, which is responsible for bone production, yet it is also responsible to coordinate bone deposition and resorption. Osteoclast is responsible to remove bone. Cementoclast are the cells that are responsible to remove cementum. Macrophages, they account for about 4% of cell population. So these are the main cells that could be found within this space. Now, the blood supply that is found in this space is derived from the superior and inferior alveolar arteries, and capillaries in the ligaments originate from intra-bony spaces of the alveolus, arteries within the gingiva, vessels entering the apex. Changes to these vessels are very important when we talk about tooth movement. Now, let's move to bone, because if a tooth needs to move, then we need to remodel the bone. So we need to know and review the main three principal components of bone. The extracellular matrix, mainly type 1 collagen, proteoglycans, and bone-specific proteins. Inorganic minerals, which account for about 67% of bone weight. It's mainly calcium and phosphate in the shape of hydroxyapatite crystals. And of course, cells, we have osteoblast, osteocyte, and osteoclast. Now, osteoblast is a cell that's derived from the mesenchymal cells, and it lies on the surface of the bone. It lies on the surface of the bone. It is responsible to produce bone organic matrix, and then it is mineralized, and then we will have the newly formed bone. It's not only responsible for bone formation, but it's also responsible to recruit and activate osteoclasts that are responsible for bone resorption. And this is done by different factors, for example, cytokines and other factors. Now, osteocyte is actually an osteoblast that becomes surrounded by mineralized bone. They become trapped inside the bone, and they don't die. They have a very important responsibility there. So if the osteoblast is trapped inside the bone, it is called osteocyte. Within the bone, these osteocytes will communicate with each other via cytoplasmic extension, which run through the canaliculi of the bone. Also, they get nutrition to survive from blood vessels which run through the center of the Haversian system. They are responsible to detect mechanical load on bone. So if there is any forces that is applied and it's transmitted to the bone, then these cells will be responsible to detect such mechanical stimuli. Osteoclasts are multinucleated cells found on periosteal and endosteal bone surfaces. So not only at the outer surface, but also at the inner surfaces of the bone. And they are found in a resorption beds. They are called Hoschep's lacunae. So as you can see, there is like a small groove or bed, and they are found there, and they are multinucleated. They're derived from blood monocytes, and they are recruited by signaling from the osteoclasts, as we said. Their job is to resorb bone, and to do so, they have a brush border adjacent to the bone surface to provide as much large surface area as possible to have an efficient job in bone resorption. Now, so we said that the tooth sits in this socket that is filled with periodontal ligament and separate the root from the bone. Now, these teeth are subjected to pressures from surrounding soft tissues. Okay, these what we call resting pressures from the lips, labially, cheeks, buccally, and the tongue, lingually and palatally. So these forces, if you look at them, they're not balanced. So the lips will be exerting forces to push the teeth lingually with about 5 milligrams of force. Now the tongue will be pushing the lower incisors about 10 grams of force to push them buccally or labially, and the upper incisors will be pushed of less than 5 grams. Okay, so if these are the only forces applied to the tooth, then we expect the upper incisor to try to retrocline and the lower incisor to try to procline under these resting pressures. Okay, so as you can see here, in some areas as in the mandibular incisors, tongue pressure is greater than lip pressure. And in the maxillary incisor region, lip pressure is greater than the tongue pressure. So why are the teeth stabilized and they are not moving? Well, the concept of neutral zone is not true because the net forces acting on the tooth does not reach zero. On the contrary, there are forces that are acting there, and what's keeping the tooth from moving is the active stabilization produced by metabolic effects within the periodontal ligaments. And this is the important explanation of having this stable position. We call this zone the equilibrium zone, okay? Active stabilization. This is not a neutral zone. This is not a balanced zone. The teeth are under pressure and this is not equal from both sides. So what's keeping the tooth from moving is the active stabilization within the periodontal ligaments. So in other words, as long as the periodontium is healthy, the teeth will be stabilized in their position. Now, let's talk about the response of this whole setup that we talked about to normal function. Okay, so during masticatory function, teeth and periodontal structures are subjected to intermittent heavy force. These terminologies are very important. Intermittent on, off, it's not sustained, okay? It's not sustained. Heavy force, that means it's, we will talk about the amounts maybe in the next lecture, but heavy force is different from light force, okay? Usually these forces will last for about 1 second or less. These normal forces from masticatory function usually last 1 second or less. And if you're chewing a soft diet, that will give about 1 to 2 kilograms of force. And if you are chewing some more cursed food, more resistant objects, then this will give up to 50 kilograms of force. This is why these are heavy forces. When a tooth is subjected to heavy loads of this type, there will be no quick displacement of the tooth. The tooth will stay still within the periodontal ligament because the surrounding fluid is incompressible tissue fluid. This fluid is incompressible. And instead, what happens is that the force that's applied to the tooth will be directly transmitted to the alveolar bone, and we will end up having bone bending in response to this mechanical force. Okay, this is true as long as the force is applied for 1 second or less. Okay, so this is less than 1 second. What happens is that the force will be immediately transmitted from the tooth to the bone, and the periodontal ligament will not change its space because of the incompressible tissue fluids inside. Now, what happens when bone bends? Bone is made of crystalline structures, and this structure will be disturbed, and the electrons will start to jump from one level to the other, and we will end up having electric current. Okay, so bone bending will generate what we call piezoelectric current. And this piezoelectric current is very important to stimulate the skeletal regeneration and repair to stay healthy. This is the mechanism by which bony architecture is adapted to functional demands. Okay, so as you can see, there is no current. As there is a force on, we will have piezoelectric current, and it will quickly decay. And then when we remove the force, then we will have exactly opposite current, same amount but in an opposite charge, which will again quickly decay. An example of bone bending: on maximum opening, the intermolar width will reduce by about 2 to 3 millimeters, and this is related to bone bending. Now, if the force is lasted for the 1 second, then a little bit of the fluid within the periodontal ligament will be squeezed out, very little, okay? The resistance provided by tissue fluids allows normal mastication with its force application of 1 second or less without pain. Of course, because we chew and it's comfortable, there is no pain. But if the pressure that is applied lasts for more than that, then we will have part of the fluid will be expressed outside the periodontal ligament space. And we will start to have some compression areas within the periodontal ligament, okay? And then we will end up having a bit some pain, especially if this lasts about 3 to 5 seconds. So this table is very important and tells you the physiologic response to heavy pressure against a tooth. And here we're talking about normal pressure during function, masticatory function. Less than a second, what happens is that the periodontal ligament fluid is incompressible. The periodontal ligament space will not be affected. The force will be transmitted directly to the alveolar bone, and this will lead to alveolar bone bending, and this will produce piezoelectric signal. 1 to 2 seconds, part of the fluid will be expressed, and tooth will move a little bit within the periodontal ligament space. If this heavy force lasts about 3 to 5 seconds, then the whole fluids will be squeezed out. Tissues will be compressed, and we will have immediate pain if pressure is heavy. And the normal reaction when this happens during mastication is immediate opening of the mouth. So if you're eating and there is a pain, immediate pain, then the normal reaction is for you to open quickly in order to relieve this pain. So this is what happens during normal masticatory function. Now, the collagen within the periodontal ligament, as we said, will be constantly remodeled using the fibroblasts and the fibroblast cells. Now, remodeling and recontouring of the bony circuit is also happening with the osteoblast cells. And the cementum of the roots is also constantly being carried out on a smaller scale. Bone contains more growth factors than any other tissues in the body, and these are important to monitor and to work within this process of remodeling. Now, the healthy periodontium is, as we said, produce an active stabilization of the tooth and produce certain amount of force that will contribute to the set of forces that determines the equilibrium situation. And we call it the equilibrium zone. Now, forces generated within a healthy periodontium can produce physiologic tooth movement. How? How is this possible? So it does not only stabilize the tooth position, but at a certain circumstances, it will produce physiologic tooth movement. This is clearly seen in the phenomena of tooth eruption. Now, tooth eruption was explained by many theories. One of these theories are the forces generated within the periodontal ligament space. Okay, and this process does not only occur during the development of the mixed dentition and permanent dentition. No, it continues throughout the life. Okay. And further eruption mechanisms depend on metabolic events within the periodontal ligament, which includes formation, cross-linkage, maturational shortening of collagen fibers. Let me give you an example. So this is a patient, this is the lower arch of a patient with an impacted lower left 5, okay? So our treatment plan was so this is the LPG and this is the impacted 5. The treatment plan was to open space for this impacted tooth. So we fitted fixed appliance. We orthodontically moved teeth around in order to open space. But as you can see, the tooth spontaneously erupted. We did not apply any active force on the impacted tooth. What made this tooth erupt is the periodontal ligament forces within the periodontal ligament space. Okay, and this process of eruption, as we said, will continue throughout life. For example, if we have a tooth that is extracted from one arch, especially the lower arch, what happens to the opposing tooth is over eruption. Why? Because the process of eruption that is found within the periodontal ligament space is continues throughout life. Also, patients who have bruxism and attrition of the occlusal surface of the teeth, if there is no such normal mechanism of eruption, then we will end up having posterior open bite if we lose tooth structure through attrition in relation to bruxism. But what happens is that we will have continuous vertical eruption of the teeth to compensate for this process. Another example is when we have an extracted tooth, then the surrounding tooth within the same arch will start to drift and will start to move around. How? This is what we call normal physiological tooth movement as a result of forces generated within the fibers within the periodontal ligament space. Okay. Okay, this is an example of a patient with both upper canines impacted and lower first premolar, second premolar. First, you can see partially erupted first premolar on the left side, second premolar not yet, and actually the lower right second premolar hasn't erupted, and we can see the 4 has rotated and has moved to in the direction of the space of the 5. So what do we need to do orthodontically is to align the teeth and start to open space for these teeth to encourage them to erupt. So in the upper arch, as you can see, by having a proper appliance, opening of space, we had immediate eruption of the canines. Of course, take into consideration that initially they were within the line of the arch and they were about to erupt, but the lack of space is the only reason they are not erupting. In the lower arch again, we moved the 4 back to its place, and as you can see, immediately we will have the erupting 5s coming through. And this is due to the, as we said, the forces generated within the periodontal ligaments. Okay, this is one of the theories that would explain the eruption of teeth. We applied no forces on these teeth, they erupt spontaneously. Right, so we're talking about the healthy periodontium. So as you can see, forces generated within a healthy periodontium will contribute not only to tooth eruption, but also active stabilization of teeth against prolonged forces from the resting pressure of lips, cheeks, and tongues. Okay? Teeth are not in a neutral zone, they are in the equilibrium zone, and they are not in perfect balance. Any disturbance of these forces will cause tooth movement. So patients with compromised periodontium, one of the features that, or one of the consequences of having such a problem is drifting move and physiologic movement of teeth due to the disturbance of this equilibrium zone. So the forces that could be applied to the teeth that are below the periodontal ligament stabilization level of forces actually are ineffective. So, in other words, as long as the forces that are applied by the tongue and the lips are within 5 to 10 grams, then these are not effective because they are below the periodontal ligament stabilization level. So this active stabilization can overcome prolonged forces of a few grams, 5 to 10, as we said, of unbalanced soft tissue resting pressures. Prolonged resting pressures could be accommodated by the healthy periodontium. They can withstand such unbalanced zone. Now, prolonged forces will produce different physiologic response, especially remodeling of adjacent bone. Orthodontic tooth movement is an example of a prolonged forces that might result in remodeling of bone and movement of a tooth. Okay. Periodontal ligament and bone response to sustained orthodontic force. So we finished what's considered physiologic and normal regarding the tooth and associated structures. And now we want to talk about the orthodontic forces. What happens when I apply a force with the intention of moving a tooth. Okay, now we have two scenarios. We have heavy forces, heavy sustained forces, and light sustained forces. If I use heavy orthodontic forces, this will lead to pain, necrosis, which is cell death, and the type of resorption of bone is called undermining resorption or indirect resorption. We will talk about this. Lighter forces, lighter orthodontic forces will produce painless process, survival of cellular elements, no cell death, remodeling of tooth socket, and the type of bone resorption is called frontal resorption or direct resorption. What I'm aiming for during orthodontic tooth movement, of course, is the second scenario. I want to have lighter forces to have a painless process of gentle orthodontic tooth movement. Now, how can we explain what happens within the socket and the tooth and the associated structures if I apply a force? Well, the biologic control mechanism from the stimulus of sustained light force to the response of alveolar bone of remodeling result in tooth movement. There are two theories that could be used to explain what's happening: the pressure tension theory and the bioelectric theory. Okay, the pressure tension theory is based on the chemical messengers, where in the periodontal ligament, the blood flow will be affected and it will initiate cascade of events of production of chemical messengers, ending up with bone resorption and tooth movement. On the other hand, the piezoelectric theory or the bioelectric theory is based on the biologic electricity produced by bone bending. Now, the first theory plays the dominant role in explaining what's happening. The second theory is still acceptable. Both theories are neither incompatible nor mutually exclusive. Okay? Now, let's talk about the biologic electricity, the piezoelectric theory first. We said that the bone and the collagen that is surrounding the tooth is made of crystalline structures. If the crystalline structures are deformed due to external pressure or forces, what happens is that the electrons will be disturbed and it will jump from one level to the other, producing flow of electric current. It is called the piezoelectricity. Examples, as we said, the inorganic crystalline materials, which is the bone, and the organic crystalline materials, which is the collagen crystals. Now, this piezoelectric signals has two important characteristics. The first one is the quick decay. So when you apply the force and the force is still there, you will have the electric signal, and then it will quickly decay. And then when you remove the force, you will have an equivalent signal opposite in direction. Equal in magnitude, but opposite in direction when the force is released. So this is showing you zero charge of the crystalline structures. And as you apply the force, you will have start of electric current. And as the force is sustained, then the effect of this force producing the current, the electric current will actually decay quickly. We're talking about part of a second, so it will decay quickly, going back to the zero. And if you remove the force again, you will have disturbances of the crystalline structures, and you will have the opposite equal in magnitude currents that will again decay very quickly. Okay, so piezoelectricity is when a force is applied to a crystalline structure such as bone or collagen, then a flow of current is produced that is quickly dies away. Dies away, it means decays. Okay, when the force is released, an opposite current flow is observed. This piezoelectric effect results from migration of electrons within the crystal lattice as it is distorted by applied force and then returns to its original form when the force is removed. But this effect decays quickly, and if the force removed, as we said, then we have equal in magnitude, opposite in direction currents that the current that will be produced. Now, electric current of electrons interacts with the ions in the fluids in the periodontal ligament space, and the electric signals, volts, will be produced, and there will be also change in temperature. These two effects are called streaming potential. Streaming potential. Now, piezoelectricity is very important in maintaining the skeleton, including bone around the teeth. And this is the problem that astronauts actually are faced with when they go to the space, because the pressure against their bone, legs, hands, skeleton in general, will be reduced due to reduce the gravity. So what happens is that they will be experiencing less amount of normal piezoelectricity that normal people on Earth are experiencing, and this will affect the general health and maintenance of their skeleton. And this is why they have to do certain exercises and certain apply certain amount of forces on their skeleton in order to enhance this piezoelectricity within their bone. Now, researchers who believe in this theory try to use this in order to enhance the tooth movement. One of the methods that is used is called reverse piezoelectricity. Reverse piezoelectricity means that you don't wait until the piezoelectric current is produced within the bone, you actually apply it from outside, from outer effects. So application of electric field to cause remodeling of bone. And this is why it is called reverse piezoelectricity. Or the use of vibration. There are certain devices that could be inserted inside the mouth. The patient bites on it, and then you turn it on, and it will cause very small vibrations in order to keep the piezoelectricity working for a longer time. And this should enhance, in theory, it should enhance tooth the bone turnover and tooth movement. A third method that is using this theory to enhance tooth movement is pulsed electromagnetic field. This is so far used in animals, not yet in humans. Now, we will come to the second theory. The second theory is the pressure tension theory. As you can see here, this is the appliance, and this is the wire, and this is the direction of force. So the force is going to this side, okay? So the opposite side will be experiencing within the socket of what we call the stretching or tension area. And then the other side where the tooth is moving toward it is called the pressure area or the compressible area. Okay, so this is the first stage or first step of this theory. Now, second, what happens is that the blood vessels diameter and flow will change. Within the pressure area, we will have the blood vessels dilating, and in the compressor area or the pressure area, we will have the flow, blood vessels will be constricted and the flow will reduce. This will result in changes in the chemical environment as the oxygen and carbon dioxide will change accordingly. Cells also will be affected. The cell's shape and activity will be affected, and it's different from an area where you have tension and areas where you have pressure. And you will end up having cascade of chemical changes that leads to bone remodeling and tooth movement. So the effect of the pressure will act on the cells. As they act on the cells, what do we have? We have the membrane phospholipids. The stimulus will activate the phospholipase enzyme, and it will work on the membrane phospholipids, and it will form arachidonic acid. And these are important in the formation of leukotrienes, prostaglandins, thromboxane A2, which are important later on in tooth movement. So as you can see, the pressure and the stimulus and the mechanical disturbance of the cells can have its own cascade of events and let's say results. So these are the three stages of tooth movement based on the pressure tension theory. Initial compression of the tissues, okay? The area of compression will alter blood flow, and we will have changes in oxygen and carbon dioxide in those areas, and we will have formation and release of chemical messengers. These will work on the cells found within the periodontal ligament space and surrounding bone, and it will cause activation of osteoblast and osteoclast, which will end up to remodel the alveolar bone. And of course, this will lead to tooth movement. Okay. Now, factors that might affect bone remodeling and maintenance of the periodontal space. Local factors are those that we talked about when the cell membrane is being affected. Cytokines and growth factors, prostaglandins, leukotrienes. Systemic factors include parathyroid hormone, vitamin D metabolites, and the calcitonin. Okay. So again, this is a cross-section of the roots. This is the tooth. This is the periodontal ligament space. This narrowed area is the area of pressure, and this widened area is the area of tension. Obviously, the tooth is trying to move in this direction. So this is the direction of tooth movement. Okay. Again, if the tooth is trying to move this to this direction here, then this is an area of tension, and this is an area of pressure. If you have a single contact point produced by a single force, then if you are trying to push this tooth, then the tooth will try to rotate. And this will produce a different diagram of distributed pressure and tension area, of course. So if you're trying to tip this tooth, then these are the areas of pressure, and these are the areas of tension. So again, going back to our first example, this is the orthodontic tooth force direction. And these are areas of tension where you have osteoblast activated and they are trying to form bone. And then these are the areas of pressure or compression where you have activated osteoclast and then resorption of bone. And you will end up having the tooth moving. As you can see, the difference between the dotted line and the main line. Okay, so let's talk about more details of tooth movement, having two different scenarios. The first one is to apply light orthodontic pressure, and the second is to apply heavy orthodontic pressure. What's the difference? Well, the first 1 to 2 seconds is exactly the same between these two scenarios, and it's exactly the same to the normal masticatory forces that we talked about, okay? So what happens if the force is applied less than a second is that we will have the fluids within the periodontal ligament are incompressible, and the force will be directly going from the tooth to the alveolar bone. The alveolar bone will bend and we'll end up having the piezoelectric signal generated. If this force lasts 1 to 2 seconds, then a little bit of the fluids will be expressed, and we will start to have tooth movement within the periodontal ligament space. Now, let's continue the scenario looking at, so these are the first and the first 1 and 2 seconds when we apply the force to the tooth. Right. So let's continue with our light orthodontic pressures. After this, between the third and the fifth seconds, what happens is that the blood vessels will be compressed on the pressure area and dilated on the tension area, as we said, and the periodontal ligament fibers and cells will be mechanically distorted, and then we will have the cascade of events that we talked about. Minutes after applying this light pressure, we will have blood flow altered oxygen tension begins to change, prostaglandins and cytokines are going to be released. Hours after this light pressure, then we will have metabolic changes occurring, chemical messengers will affect cellular activity, enzyme levels will change. Around 4 hours after applying the pressure, we will have increased cyclic AMP level, and cellular differentiation will begin within the periodontal ligament. 2 days after applying this light, gentle pressure, we will start to have tooth movement will begin as the osteoclast and the osteoblast will start to remodel the bony socket. Okay, so this is showing you the area of tension where we'll start to have occluding, sorry, not occluding, what do you call it? Partially, the diameter of the blood flow, the blood vessels will reduce. Okay, they will be squeezed, and this will affect blood flow. There's a compressed, they will be compressed, yes. And this, at the end of this light pressure applied to the tooth, what happens is a type of resorption that is called frontal resorption or direct bone resorption. Why? Because all around this area here, we will have osteoclast working from the side toward the periodontal ligament, and they will start to have bone resorption and bone removal, and you will have, let's say, gentle, continuous tooth movement within this area. So this is a diagram that shows you the relationship between time in days and the tooth movement in millimeters. So to start off with, we will find that the tooth will move the distance that is equal to the periodontal ligament space, right? Because it will start to have pressure and tension sides. And then only after 2 days, if we're talking about the red line, which represent the light orthodontic pressure that is applied to the tooth, after 2 days, we will have the frontal resorption, direct resorption, and continuous tooth movement. Okay? Now, let's talk about the other scenario. And the other scenario is when we have heavy pressure. So the first 2 seconds is the same. And now we will move to when we have 3 to 5 seconds later, what happens is that the blood vessels within the periodontal ligament at the pressure area will be occluded. Minutes later, blood flow will be cut off. And then hours later, we will have cell death. When I say cell death, it means hyalinization. Hyalinization is an area of cell death that looks like a glass appearance on a microscope. Histologic appearance is a glass-like appearance. 3 to 5 days later, we will have cell differentiation, adjacent narrow spaces, undermining resorption. Resorption will start from not the side of the periodontal ligament, but from the inside. Okay, so we will have undermining resorption. And only 7 to 14 days later, we will start to have the undermining resorption will remove lamina dura adjacent to the compressed periodontal ligament, and then we will have tooth movement will start to occur. Going back to the diagram, I'll come back to this now. So this is a normal light pressure, as you can see, only we have compressed blood vessels. But heavy force will lead to occlusion, a total cutoff of blood vessels. Right. So the first slide here, histologic slide here, will show you the tooth movement with the frontal bone resorption. Sorry, this is the frontal bone resorption. As you can see, these are the osteocytes with multinucleated, and they are recruited beautifully at the periodontal ligament side of the bone, and they will cause frontal bone resorption. On the other hand, here, you will have this glass appearance of hyalinization, heavy forces, and the osteocytes will start to work from the inside out. So they start to resorb bone from the inside, and then they will reach the periodontal ligament, and then you will have a sudden movement of tooth, what we call the jump, a jump of tooth. This slide here shows you the tension area, and the tension area you will start to have osteoblast activation and the new bone formation on this side. Now the tension side affects whether you applied heavy force or light force, the tension side is the same, okay? So you can see here, on the tension area, the same response will happen. It doesn't matter if you use light force or heavy force. You will have dilation of the blood vessels, and you will have activation of osteoblast and then bone formation, bone deposition. Okay, but the pressure area response is different according to the amount of force that you applied. Going back to our diagram, so we talked about the red line and the light forces, now the heavy line. As you can see, when we start to put the force, you will have an initial tooth movement that is equal to the periodontal ligament space. And then we will have delay, because this is what happens during this delay, undermining resorption, okay, indirect bone resorption. And then between 7 to 14 days, you will have a sudden jump, sudden tooth movement. And then you will have another shorter period of delay, and then another jump, and so on. Okay, so as you can see, heavy forces does not produce faster tooth movement. As long as both forces, light and heavy forces, are above the optimal force needed to move the tooth, then both of them will produce the same amount of tooth movement, but the heavy forces will be less comfortable, more pain, and more risk of root resorption and hyalinization, cell death, etc., etc. So in orthodontics, we aim for the red line, light, gentle orthodontic forces that will produce gentle tooth movement. Right, so just to show you the osteoclast activity in bone resorption, where we have the direction of tooth movement, and of course osteoblast activity on of course it's on the other areas of tooth or tension areas. Right. So this is to show you the difference between frontal resorption and undermining resorption, okay? So here we still have blood vessels. They are compressed, but they are still there, okay? And then we have the osteoclast acting at the frontal line here, at the side of the periodontal ligaments. So this is what they call frontal bone resorption. So they act on this side. This is an example here, down here, of heavy forces. Blood vessels are occluded, and then you have hyalinization and cell death, and the osteoclast will work from the inside. They will start bone resorption from the inside, and then when they reach the periodontal ligament, we will have a jump of the tooth, and we will have undermining type of resorption. Okay, so this is mainly the first two headings where we talked about the normal physiologic tooth movement and normal function and response to normal mastication. And we also talked about the response to orthodontic forces, heavy and light forces, and the difference between them. So I hope the questions that we raised at the beginning of the lectures are now clear. You need to know the difference between them, between the normal physiologic tooth movement and the orthodontic forces that produce tooth movement, orthodontic tooth movement. Next lecture, we're going to talk about types of tooth movement and more mechanical part of this story. Thank you for listening.